Welcome to The Pod, a podcast for women in healthcare leadership, a heartfelt space where women executives in healthcare and their allies unite to support and uplift each other with personal stories that inspire positive change, nurture optimistic mindsets, and celebrate diverse perspectives. I'm your host, Dr. Kristen Woods. Today on The Pod, a podcast for women healthcare leaders, I have the absolute joy of welcoming someone whose presence lingers long after she leaves the room, Dr. Karima Velji. I first met Karima at a conference a few years ago, and there was a line of people waiting to speak with her. And what struck me was the way she met each person with genuine warmth, eye contact, and her full presence. She never looked past that person to the next conversation. In this sea of busy leaders, Karima was the one who made every single person feel like the only one that mattered in that moment. I remember thinking, this is what true leadership feels like. And then you look at her work, and the impact is extraordinary. Karima is the chief of nursing and professional practice and an assistant deputy minister for Ontario. And she's leading the province's integrated health human resources strategy. Her portfolio spans education expansion, including 2 new medical schools, scope of practice changes like RN prescribing and the pharmacy minor ailments program, accelerated pathways for interjurisdictional and internationally trained practitioners, and major retention and distribution initiatives across the province. She's a registered nurse, a respected system-level strategist, and a senior leader with deep experience across academic, health science centers, and boards. She holds multiple university cross appointments, an honorary degree from Loyalist College, and is a sought-after consultant known for leading complex external reviews. She also serves as a surveyor with Health Standards Organization and Accreditation Canada. Further, shaping the quality and safety of care across the country. Beyond all of those accomplishments, what I admire most about Karima is the way she leads with both brilliance and heart. She embodies what we aspire to be on this podcast: strategic influence paired with deep humanity. Karima, it is an honor to have you with us today.
Thank you so much. Thank you for inviting me to this podcast. It's my pleasure to be here.
Well, it is our absolute pleasure to have you, and I can't wait to dive into the questions. So, you're leading one of the most ambitious workforce transformations in Canada's history. Can you take us back, though, a bit earlier in your career and share, was there a moment when you realized you wanted to move from bedside nursing into system-level leadership?
I've never actually planned my career, but I've been open to opportunities that may arise and a door that I may walk into, and that's how the transition happened. The first half of my career was embedded in clinical practice and research, and I was a nurse practitioner in cancer care at Princess Margaret Hospital for most of that time. And then somebody pulled me into an administrative role at Toronto Rehab, which is, as you know now, an organization that's part of the University Health Network. There was a chief of nursing and professional practice position that came open there. And the big challenge was to link the world of clinical care and research together, because it was a new academic health science center. So the then CEO at that time, Mark Rochon, basically pulled me into the organization. And of course, I was very worried because I loved my practice role and I loved the day-to-day care of patients and so on. But embarking on that journey of system leadership It's just you realize you're going to make a difference in a different way, basically, in a more systematic way. You're making a difference to systems, to structures, to processes that touch patient care. So ultimately, the focus on those that you serve continues regardless of the domain in which you practice.
I'm interested in your comment that you never looked for specific leadership roles. It's something that my husband and I, who's the CEO of a hospital, we talk about that a lot, that his career, he never aspired to be a CEO of a hospital. He kept taking roles that he felt he could have impact in or that drove his mission. And it sounds like you followed that same philosophy.
Yeah, the driving force is doing better by the people that need care, that need our services. So it's quality and safety. That's been the core driver of my leadership roles. And all the roles that I've now occupied in an administrative kind of domain have been leading patient care, leading quality and safety systems, professional practice in organizations. So just progressive leadership roles touching those elements. And then, of course, this ADM opportunity once again came up, not by career design by any means. It was 3 years ago, actually, that I stepped into this role. And then the then Deputy Minister, Catherine Zahn, said to me, we need someone who has really touched some buttons of innovation, basically in the area of integrated care and health human resources, and who have kind of transformed some HHR systems on the ground, health human resource systems. So we need someone to come and push those buttons of innovation for our province, because doors have opened during the pandemic and after, because a crisis blew up, as you know, for health human resources all over the world, which created opportunities and doors that have not opened before. So she said, someone who's at that stage of career where you have nothing to lose, basically, and you can come and push on some things and bring people along, basically, so that we can make the shifts that we need.
That's incredible. And I'm thinking about all of those shifts that you've made and transitions that you've made. And for a lot of women leaders, and some men leaders too, they experience moments of self-doubt. Someone taps you on the shoulder to take this new role and bigger role, and you think, can I do this? And so you were tapped on the shoulder to take on some substantial roles. What gave you the courage to say yes?
First of all, I'm a bit fearless. And I think with age, more fearlessness has come. So I don't doubt myself usually, but even if there are doubts, you fake it till you make it. Like, of course, there will be a moment where you are new to the system. You're going to learn the ropes of the system. And government was a very new area of practice for me. I'd never worked for government. So just coming in and learning the ropes of how decisions are made, how you undertake briefings, what do the various acronyms mean. I'm pretty forgiving to myself in that, of course, it's going to take me a little bit of time to learn the ropes. But in the meantime, I am bringing a significant area of expertise into the shop as well. And I came in as an N of one person. I didn't have a division. I didn't have a group of people to lead. I came as an N of one person and was parked in the ministry, not knowing any of those things. And I thought, well, I'm going to turn this challenge into an opportunity. So I started to park myself, whether I was invited or not, into various conversations, no matter what sector they pertain to. So I would go into hospital briefings or home care briefings or briefings about primary care, and just intimately became aware of, okay, I'm going to be a cross-sectoral leader here, not in any one silo. And HHR, Health Human Resources, pertains to the whole of the ministry and beyond the ministry. It pertains to the Ministry of Long-Term Care. It matters to the Ministry of Community and social services as well. So that time of, oh my God, I thought, wow, what am I doing here as an end of one person? And I don't even know how to make my next step. Turn that into basically an opportunity and become relevant to the groups and try and help them solve their problems. I mean, that's the way you become, what shall I say, relevant in any organization, is you become in service to others. You are not going to undo things that have been historically in place right away, but you kind of embed yourself in a team. You help them solve their issues and problems, and you try and win hearts and minds. Open those up basically, and then try and influence, start to introduce the wherewithal and the changes that need to be made. But it's not like pulling a Band-Aid off. You have to win the hearts and minds and bring people along, whether they're inside an organization or external stakeholders. And I have a big role that pertains to external stakeholders. I could not do the work I do if the schools were not doing what they need to do, or the regulators were not doing what they need to do. I'm just ever so thankful to them that they have not only come along, but they have actually come to a place where they now push our thinking. Like, it's truly remarkable that in a 3-year span, we have completely shifted our mindset around how we do regulation, for example, for healthcare professions, or pathways to registration, or how we educate healthcare professions. None of that would have happened if people on the ground who are in the face of change, in the interface of it, are not doing what they need to do and pushing our thinking along the way.
That is one of the most elegant descriptions of servant leadership that I've heard. And you described it so beautifully from your own mindset of being agile, being open, focusing on what you bring, and giving grace while you learn what you need to learn. And then also giving others the same kind of grace and looking for ways that you can serve them. And this leads to my next question, which is, you do work across a great number of stakeholders, internal, external, physicians, nurses, pharmacists, regulators, people that have licenses to defend and protect. How do you bring these different groups together when they have different competing interests and there may be trust issues between them? How do you bring them together and get them aligned into that single common vision?
Well, you have to listen deeply, and you can't impose. Whether you're in a position of authority or influence, you really cannot impose your view on people and control it. It's not the way to lead. I've never led that way. You have to listen deeply and kind of co-approach a problem. Like, there is an issue, and we are together in the service of solving a problem or a situation. So you kind of have to get to the common denominator, which for me and the people who we work with is always the people we serve. It's the patients and the families who need our care desperately. Never has the time been so great where the supply-demand challenges face us in the way they do. Like, never in our history have we faced this kind of supply-demand gap. It's getting better, thankfully, but post-pandemic, it was scary for a while. So you have to get it down to what is the common interest of all of us. It's the people we serve. So all conversations start from that perspective. And now, with some wisdom I've gained with age, I think I've become a little bit more impatient towards action. Because I'll tell you, some of the conversations during the pandemic and after, when the health human resource challenge blew up, was on one side of our mouth, we were speaking about a crisis. This is a crisis. This is a huge challenge. It's historical. And on the other side of the mouth, the system didn't want to change. Like it was so rooted in some of the traditions and the histories that served us well in the past, but they are not going to serve us well in the present and in the future. So I became a fan of not doing coalitions and big tables of stakeholders that meet endlessly and relentlessly to talk about the same things over and over while we have to initiate actions and solve some problems. So I became a big fan of bilateral and trilateral relationships. And that means you have to be clear about the problem that needs a solution. And who are the absolute key partners who have to be a part of that solution? And you try and win them over one by one, rather than at a table, because dynamics at a table change. People posture for each other or for whatever reasons, and there is no time for it. There is no time for it because the doors are open, we have to walk through them, and the problems are such they need kind of relentless action now, not 10 years from now. So that's how we came up with our HHR strategy. And then we started to move each element of the strategy with the right critical partners. And even within the stakeholder groups, so for example, if we wanted to drive some innovation in the education space, the approach was if we try and win over the hearts and minds of everyone and wait for the whole university and college sector to come along, we'll never get there. So who is ready? Who are the first movers who are ready to move? Let's put some money on the table, do a call for proposals, and start to innovate through first movers. We will make some mistakes when we do that because it's innovation. Not everything will fly, but at least we will try something different and we will try and move it forward and we'll evaluate it. If we need to change the course, we'll change the course. That's how we've shifted the landscape of education expansion here. Scope of practice is another great example. Oh my goodness, we were stragglers. In Ontario, we were stragglers. We were 10 years behind the Western provinces where scope of practice of healthcare professions was concerned. And scope is a great way to inflect your professional capacity in the system all at once. So yeah, scope of practice was an area where we were stragglers in Ontario. We were 10 years behind the Western provinces who had done pharmacy minor ailments 10 years before us, RN prescribing 10 years before us. Mind you, we were shining in the nurse practitioner scope of practice. We were always leading in Ontario on that front. But here came an opportunity where you're saying, how can we inflect the capacity of the workforce that's already in the system? Well, if they all work to top of license scope, immediately the 60% capacity will turn to 80% capacity in the system. Everyone will be working at this level, which will allow physicians and others to do more complex work. They will inflect to their right level and opportunity as well. And we will serve people better.
Yeah.
So we used evidence, and where we couldn't use evidence, if evidence was not enough to turn someone around, we just stood up to that power. To be honest, like there is no time to waste. So you can't continue to be fearful about someone's alternative voice and perspective. Let them have that alternative voice and perspective. We have to have ours. And so long as there is a body of evidence guiding us, let's carry on. No one has died in Alberta because pharmacy has been doing minor ailments. There's vast bodies of evidence to show that. Why shouldn't we do this in Ontario? And here we are, alive with 19 minor ailments, and we are about to add 14 more.
I saw the sign in my own pharmacist window that listed the minor ailments that they can address and prescribe for. And I thought, that's great. That's innovative. We've some of the work that I did in the U.S. with our medical group was to build those same type of interdisciplinary teams where people could practice to the top of their licensure. And I want to go back to something, again, that I think you described in action so beautifully. And we talk about who are identifying the right stakeholders to move forward to action. And oftentimes it's, I think, a human tendency, especially if you're an empathetic leader like yourself, to listen more to the naysayers or the people that are putting up the most protest instead of really engaging the innovators that are going to move forward, and then focusing on that middle that's undecided. And by giving more attention, resources, and energy to the people who are ready to move, you can win more of that middle group and get them to be the early followers and the late followers. Do you have any examples of where you've seen that take place too, by not ignoring the naysayers, but giving them, as you said, the space to voice their concerns, but then moving on and saying, we hear you, we're going to do this, here's the evidence, and we're going forward. Do you have any other examples to share?
The part of the HHR strategy that I am very proud of, I'm proud of everything, but the thing that's very near and dear to my heart is the work we've done that's really equity work as far as I'm concerned, where we are expediting the pathways to registration and giving interjurisdictional and international practitioners their true opportunity to practice. In Ontario, I remember when I came to the ministry, we were just coming out of the Omicron wave of the pandemic. And we were at the worst stage of the supply-demand gap for HHR. And at that time, the nurse in me said, are there any healthcare practitioners, including nurses, in the system who could be practicing, but who are not? Because there's our first opportunity, is to grab anyone who has the potential to be a nurse who's not a nurse in the system. And we discovered thousands, not hundreds, thousands, almost 10,000 nurses stuck in the regulatory pathways who had the right academic credentials from their home jurisdiction, often equivalent education to the education standards in Ontario, but for whom it was taking up to 2 years to register them in the system. And in those 2 years, we would make them take upgrading courses. We would send them back to their home countries to do 3 more years of practice, because your 10 years of practice in ICU is not good enough for us. All practices, I call them systemic bias, systemic racism really in the system, that said, you're not good enough for us until you are. And I thought, I'm an immigrant to Canada. I grew up in Tanzania. I know when I came here in the early 80s, my high school credential from back home was not good enough for this country. So I had to go back as a mature married student and finish high school, the last year of high school here, so I could get into nursing school. And I thought, I've been given this privileged opportunity to be in this position. If I cannot touch this, why has someone put me in this position, for God's sake? You have to take the privilege, I think, of your leadership, the leadership opportunities that you are given, lead from there very deeply. And I thought, this is something I'm going to put my personal fingerprints on. So the first thing we did was systematically just started through regulations, without changing any legislation, started to remove the systemic barriers. So any additional language requirements, additional upgrading requirements, etc., we started to remove those from the system, basically, because these people had come here through an immigration process. They had passed the English exams. that are part of the immigration process, why do you need more upgrading in English? And you've studied in English in your back home jurisdiction. So we started to we removed about 20 barriers away from regulation. So all the systemic, basically barriers, and started to expedite the pathways to registration. And we started to measure the time it's taking from people who register, who kind of say, I want to get registered, and the time it took them to finish their registration process with the college. We also issued a minister's directive under a legislative landscape that we have here, the Regulated Health Professions Act, and said the minister directs to colleges, nurses, and physicians to expedite your registration pathways for international and interjurisdictional practitioners because we need them in the system, and they're good enough for us. They're pretty good enough. They have the right credentials, but do register them, go through the due diligence process as well. Anyways, out of that came then a legislation that we enacted called the As of Right legislation, which allowed, because funnily, we were not only doing this to people who are international practitioners, we were doing this to Canadians, people who were coming to us from other jurisdictions in Canada. Do you know when a nurse goes to the US, a Canadian nurse, no matter which jurisdiction they go from, they are put to work. The US recognizes our credentials. We did not even recognize each other's credentials. So a BC nurse would have to come and reapply to be a nurse in Ontario to get re-registered. So we implemented As of Right, which removed the need to get registered for a 6-month period. You can just start to come and work here, but do get registered because we need oversight for any physician or a nurse or any regulated health profession. And then we've moved to automatic recognition of license, which will come into shape January 1 of 2026. So we will be the first province who will recognize a BC license of a physician and a nurse as being equivalent to the license in Ontario. This is something I dreamt of 40 years ago when I graduated as a nurse from McMaster, and I thought, why can't a BC nurse just work here?
Yes.
In Ontario, they have taken the same CASN approved curriculum and they've written the same exam. It's the MTEX exam now. Why? It's the why question has occupied my mind for almost 4 years. And of course, once you're given this kind of opportunity to lead system change, you have to push on these buttons and automatic recognition. It's like having a national licensure, but Ontario has now moved first. We didn't wait for the whole country to be ready to move, because then you'll wait till you turn blue.
And you said, I want to be action oriented. And I need to pause and celebrate you for turning a 40-year frustration into action and getting this legislation through. That's worth celebration. So congratulations for your work and effort and vision and taking down those barriers.
You have to know your stuff. You have had to do it on the ground. You have to have some experience with it. And then you have to know how to convince the decision maker, because remember, I'm not a decision maker. I'm not the elected official. I'm a bureaucrat in a Ministry of Health, the biggest ministry in government. So I have to convince the Minister of Health and the Premier that this is the right thing to do. And I have to applaud, I have to tell you, our minister is a risk taker. And she loves it when we take Ontario to the front of things and try something new and innovative. And it's with eyes wide open, because when you move first, you will see issues and you'll have to deal with issues, which we do sometimes. But ultimately, the advantages have far outweighed the disadvantages. It's been amazing. But people have come along. So you also have to know how to brief the decision makers to move the decisions in the right way as well.
Yes, absolutely. And that one of the things that some women leaders can struggle with is balancing being assertive or not assertive enough. And it sounds like you've really found that perfect tension. What's your secret? How do you be assertive and warm at the same time?
I am out and about a lot, and this is something I've decided to do because in a role like mine, an ADM role, you can get pretty stuck in your office. There is much to do. There are many briefings that come at you in an hour. My calendar can change in a heartbeat. So you can completely drown yourself with the internal work of the ministry. I've decided, no, this will be balanced with external visibility and presence, which makes for an 18-hour day sometimes.
Oh my.
It does, but I like it. That's the only way I can lead is having my ear to the ground and being real. I miss practice a lot. So I have to get near it to replenish myself. And that makes you very relevant and credible. So any briefing I will try and give to the minister or the premier's office or whoever, it will kind of start with a data element and a story. Minister, I was at Trillium or in a hospital in Newmarket last week. I wanted to just share with you what I saw. I just start with some kind of a narrative or a story that captures someone's imagination. And then you're ready in your mind to receive the signal that I'm going to send to you. So then you also have to watch your signals and noises. As a nurse and as an East Indian woman, I'm long-winded in how I speak. So I have to really watch when I'm briefing decision makers. There is no time to waste. They have a 2 or 3 minute attention span, and you have to get your message across in that time. So a quick narrative, and then the pitch has to be made. The signal has to be pretty strong and not noisy. Not noisy speak so that the data is given, the story is given, and then you are clear. I've done my best here. The decision is in the decision maker's hand now. And sometimes, or most of the time for HHR, I'm very blessed. It has worked. There are times when it doesn't work. And I've learned here, don't die on that. Wait. Do not lose the idea. Park it on the side, because when the stars line up again, you should be ready to unearth that idea and pitch again. So it's never say die. Never say die. When that political calculus or moment happens, your idea could be golden again.
I am so fascinated by your agile mindset, and you're tying together so many concepts that we've talked about on the pod, but also that I coached leaders to. When we talk about executive presence, it's that mindset that's agile, confident, but humble and values driven, and the expression of your thoughts, which is in your behaviors, choices, and in decisions that you make and how you choose words. And then that authenticity that builds connection through emotional intelligence. And so I think that's my little framework for executive presence that you do so well. And on top of that, you're so clear. Clarity is one of our biggest challenges that make initiatives fail or not start. And sometimes with those setbacks, if you're still clear about your mission, for example, to 40 years ago, to take down some of the regulatory barriers that are interprovincial, and you stay clear with that, and then when the door opens and that moment presents itself, you're ready to go. That only happens if we're super clear about our vision. And I just feel like your whole story explains all of those pieces in such a beautiful way.
But your stakeholders also have to be ready, because I can sell a good sale to anyone, if I choose to. But if you're a stakeholder, you haven't built a relationship with the colleges, you haven't helped them solve their issues, and it's not authentic, it's then that voice or that brand that you're trying to sell gets disjointed.
Yes.
For me, it's very important that if I'm pitching something to our minister, that there are 2 or 3 stakeholders who are ready, the key ones, to support that idea. So I will be testing the idea, I will be getting their perspective. It's kind of baking a cake to enough level so that when the pitch happens and the support is there, you just have to take it out of the oven and go.
Yes.
Or eat the cake. But it can't be now a big fight on the ground. Your people have to be ready. And this goes for internal teams as well. Like it's impossible to do the work alone. Your teams have to believe in the same thing and be coming along or be influencing your thinking or making it better. So it's crucial. It's crucial that your ears are open, you are listening, you are ready to shift your perspective. You're not getting stuck in your own kind of drinking your own Kool-Aid, basically. And when people see that, oh my God, yeah. When a different set of facts were brought in front of this individual, she could shift her mind. She didn't get stuck in one way of thinking. I think it really builds trust.
Yes. And you make it easy to say yes.
And don't whitewash the risks. I mean, we've done some very big things here. We've taken risks. So you kind of have to be clear as well when you're painting the risks of an initiative. And in a political arena, the risks really have to be painted clearly because it's very political. People's political careers depend on how something will be successful or not. So you are also going to paint the other side of the story, not just the side you believe in, clearly, and then people will trust you've thought through something with clarity.
Yes, it's not just painting the optimistic picture and the state of euphoria, but realizing what the risks are and then offering ways to mitigate them, and also being willing to talk about how much risk you're willing to take.
Exactly.
I love that. So over your career, clearly you've faced resistance and setbacks. You're working 18-hour days sometimes. How do you maintain your resilience and optimism during those challenging times?
I've done this in all my leadership roles is I try to get close to the action, to the place where care is being given. It fills my cup. So even when I was, say, a chief nurse of a hospital, there would be regular times that would be embedded in my calendar where I would go up to a unit, sit with some caregivers or patients, and just listen. Listen to what's working well for them. Is there anything I can do that will make your life better? Because I understand you're going through a big struggle. That really fills my cup. And I do this in this current role as well. I'm probably for 1.5 days of the week trying to get out and about, seeing our stakeholder groups, but more so being in the care areas, whether it's a home care visit or a primary care setting or hospitals. Just being in the face of the interface of patient care, it really fills my cup. And on a personal front, our family is a big thing for me. As I said, I'm East Indian by background, so I have a very big immediate family, but big extended family as well. So it's being constantly in touch with your family. My granddaughter, Zoya, has the best ability to help me forget about work. When she's with me, I can really turn off. So she's built into my day or my week in very purposeful ways because it's pure joy. And you have to do that because it's the work will be here tomorrow. Family and health talk. It's the top of the list. I've learned this the hard way. I've come into it learning it the hard way. I had to lose some things or lose attention to it to understand, oh my God, I do have to make this the number one priority. And I try and impose that on my teams. Your health and your families are number one. The work will follow that, because you will be good to no work if you're not good to yourself and to your loved ones. So I try and live by that. I can't say I always succeed, but I try my best.
None of us are perfect, but I can see how you're a master of building relationships, both in your professional life, but also in your personal and family life. And it's more than just our intentions, but it's marrying that intention with action. And Karima, I'm going to bring us to a close. I could talk to you for hours. And the pod is about making waves. WAVES is an acronym that represents Women Amplifying Voices and Elevating Success. It's our commitment to enriching leadership through diverse perspectives, authentic storytelling, and collective achievement. And it's about lifting each other up to new heights and really redefining success as something we build together versus alone. So here's the final question. If you could leave our listeners with one challenge or call to action that advances our collective success in healthcare leadership, what would it be?
Ask the why not question. It's something that has really worked for me with my internal team. So the mindset is that of innovation and asking the why not rather than the why. And be eternally driven by the people that we serve. So when the primary care attachment is not what it needs to be, it should get under our skin. When mental health and addiction care is not the way it should be, and people are waiting for long periods of time, it should get under our skin. So not to look at those issues as simply numerical problems, but they are actual people's lives that are being affected by it, and let it get under the skin, because that will drive the action orientation.
I love that. It's stories that we connect to, relate to, and see ourselves in that drive that connection and then action. Thank you, Karima, for being on the pod, joining our community, and leaving us with so much wisdom. It's been an absolute pleasure to have you here today.
Thank you so much for your time and your lovely questions as well.
And I'm going to pose 2 questions to our listeners. The first is about building trust across difference. So Karima leads change across groups with competing interests and deeply held professional identities. So think about a stakeholder relationship in your own work where trust feels fragile or absent. And what's one concrete action that you could take this week to build a bridge, not by compromising your own goals or values, but by genuinely understanding their perspective and finding that shared ground? It's what Karima talked about with deep listening and finding that shared purpose. And the second question is, I'm going to challenge you to find the courage to step into something that feels too big. Karima's taken on big roles, redesigning an entire provincial health workforce system. This challenge, I'm sure, felt impossibly large at times. So when you reflect on that next opportunity that feels too big for you, I want you to ask yourself, why not?
Thank you for listening to today's episode of the pod. I invite you to join our pod every month as we empower one another, fostering a world where women in healthcare leadership thrive.